Absolutely. ASH is a very interesting conference. I'm always very excited to participate, to attend ASH because it's very focused on hematology. And you'll have interesting topics on the classic hematology, benign hematology, but also on malignant hematology. So it's a dual. It's dual from this point of view, and it's interesting. It's also a lot of networking, and you get to see former colleagues and investigators that you worked with. So it's a wonderful opportunity, and I'm always grateful to be able to attend that conference. So a plethora of amazing topics. It's very difficult to choose what to attend. So you really need to make the right decisions. What sessions are you going to go? I wanted to go to some of the sessions on benign hematology. I worked for many years in hemophilia, so I wanted to see what is the progress in hemophilia. I was specific. I wanted to see what is the progress in gene therapy in hemophilia. And although gene therapy has been around in hemophilia B for quite a few years, right now we have data on gene therapy in hemophilia A. Hemophilia A is the majority of the patients with hemophilia. It's a lifelong disease. The patients need to be treated from early childhood with prophylaxis, and not all the countries have the means to treat these patients properly with the right standard of care, so they avoid the later complications of the disease. And some of these complications are, the patients bleed in their joints, and they become gradually immobile. So treating these patients early on with gene therapy is actually amazing. And there was data showing that one single injection with the experimental drug basically transformed the severe and moderate hemophilia in mild or better. And it really decreased the annual bleeding rate significantly. And these patients didn't need prophylaxis anymore. So huge progress for these patients with hemophilia A, considering that about 80% of the hemophilia patients have hemophilia A. And the gene therapy was more difficult in hemophilia A because of the dimension of the gene. So it was more difficult to approach the gene in hemophilia A compared to B. But there is hope there. And the safety profile was very good for the experimental arm. So hopefully this is going to become standard of care. Beside hemophilia, there was also a lot of data in sickle cell disease, which is also another terrible disease. And hopefully all the subtypes of the patients with this disease will have available treatment soon. In terms of malignant hematology, there were so many topics and so difficult to choose what to attend. But I think one of the most important sessions that I always try to attend is a plenary session, and I think I was very impressed about the result. All of them, all of the communication in the plenary are extraordinary, but one of them is really impressive because it's in pediatric, in a pediatric cancer, in pediatric ALL. Pediatric cancers are extremely impactful. They happen in children and they have really no fault, and it's very emotional for the patient, for the family, for everybody that treats pediatric cancer. So I have to say that acute lymphoblastic leukemia was a universally fatal disease. In the recent years, there has been done a lot of progress. In this disease. And I think the introduction of immunotherapy, like monoclonal antibodies and the CAR Ts, made a huge difference in the prognostic of this disease, and the patient outcomes have become better. And we do have now a great survival rate, a grade 3 disease-free survival rate. But this study, which basically used a different treatment schema. They basically utilized blinatumomab together with chemo versus standard of care. And in the experimental arm, the patients actually had disease-free survival at 3 years of 96.6%, which I think is a tremendously successful rate. And versus the standard of care, which is 87%. disease-free survival rate at 3 years. So it was a very successful rate to begin with, but it basically shattered the glass ceiling with the study. And this treatment has become instantly standard of care. So huge change of practice in pediatric ALL. I'm always drawn to the multiple myeloma sessions. I did work in multiple myeloma for many years, and this year they focused also on the early stages of the disease. So smoldering myeloma is basically the stage of the disease before the patients are diagnosed with active multiple myeloma. And the standard of care is basically active monitoring. So the patients are not, a standard of care right now, the patients are not receiving any therapy. Yeah, so the patients are actively monitored. So this study, which is called Aquila study, was a phase 3 randomized study where the patients received daratumumab monotherapy versus the standard of care, which is active monitoring. And the results were in favor of the treatment group. So daratumumab monotherapy actually had significant progression-free survival improvement in patients with high-risk smoldering myeloma. It also demonstrated a very good safety profile. There were very low rates of discontinuation in the treatment group, so this becomes a very feasible solution for these patients with high-risk smoldering myeloma. It also, beside the progression-free survival, it also extended the overall survival versus active monitoring. And smoldering myeloma has been approached many times. Until now, it's not the first study that is being done in smoldering myeloma, but standard of care hasn't changed. So I'm very curious if this result is going to change the standard of care, and the patients are going to, especially the high-risk patients, because the benefit was observed, especially in the high-risk smoldering myeloma patients. And I hope the standard of care is going to change, because it was an obvious progression-free survival and overall survival benefit for these patients. Another big study that had results, it is actually interim. It was an interim analysis, so it was basically a first glimpse in the results of a randomized controlled study in CLL. But what was important here is that this study was in the first line CLL, so in treatment naive CLL patients, which we do have a quite big armamentarium of agents to treat CLL. Is the BTK inhibitors, is the BCL2 inhibitors, and the monoclonal antibodies. So a lot of combinations and the role of a lot of regimens for these patients. However, this study was basically looking at 3 arms. 2 of them contained venetoclax and a second-generation BTK inhibitor, acalabrutinib, with or without obinutuzumab, which is another monoclonal antibody. So we had 3 arms. We had AV, we had AVO, and then standard of care, chemotherapy. And the interim analysis actually showed that the AV and AVO arms significantly improved the progression-free survival in these patients. And not only that improved the progression-free survival, but also the overall survival in both AV and AVO arms. So I think this is very important data, because it has the potential to change the standard of care in first-line CLL patients. And what was also important to see is that the AV and AVO arms had actually very good safety profiles. And one of the things that we're looking when we work with BTK inhibitors is the cardiac toxicities. And this interim analysis actually showed the low incidence of cardiac events that are usually associated with BTK inhibitors. So great result for this interim analysis, and looking forward to see the final data. the final study data. I don't know when it's going to be communicated, but I'm sure it's going to be soon at the next conference. There were also a lot of sessions on how to handle different toxicities. Right now, CAR Ts have become uh, quite a common treatment in hematologic malignancies like lymphoma and myeloma. And there was a wonderful sessions on how to handle the toxicities, very well attended, looking at practical aspects. And I think there were quite a few sessions at this ASH looking at the practical sessions on how to handle toxicities and how to do different things. So again, very well attended sessions and very important for clinical practice, but also for us in clinical trials, because it's very important when you design a protocol to know how to actually write about, prophylaxis and toxicities, and to be aware of what concomitant medications shouldn't be used in the context of a clinical trial, and so on. So a lot of learnings from that session. And I could not finish my summary about ASH without talking about artificial intelligence. There was a session on AI, um, very interesting, and some of those concepts are absolutely mind blowing. But there are AI is trying to improve the way we do clinical trials. So um, the gold standard of clinical trials is randomized control trials, yes, but there are a lot of difficulties in putting these studies together, and one of the biggest issues is that the patients will not accept to be treated. They want to be treated with the experimental drug, yeah. They don't want to be treated with the standard of care. So it is very difficult to randomize and to find these patients to accept. Yes, I will be fine being treated with any of of these therapies. So a solution that AI can provide is basically synthetic patients. Yeah. So and it has already been experimented, and there are already publications out there using an experimental cohort and the standard of care cohort being synthetic, being comprised of synthetic patients. So basically, the AI is creating these patients based on the data that has been accumulated. I think the training of the AI is very important on how they choose and how they program these synthetic patients. So they basically behave like real patients. And these cohorts of synthetic patients basically mimic the conventional treatment scenarios. So it's a very interesting concept. And there are several benefits to utilizing synthetic cohorts. The fact that the real patients receive only experimental drug, and it reduces exposure to less efficient therapies. The enrollment for sure goes faster because you have to enroll basically real patients in only one cohort. It costs less, of course. And this approach can be extended to any setting of a clinical trial. And again, this would be the benefits of this technology. However, of course, there are a lot of open questions about this, and how the biggest question is if the regulatory agencies will accept data that is coming out of clinical studies that use synthetic patients. So there are a lot of regulatory issues that have to be sorted out before this can go, in the standard clinical trial practice. Right now, of course, there is a lot of skepticism regarding synthetic data, but that can be alleviated with studies that are going to show that the synthetic cohorts are mimicking very closely the real patients. And of course, I think one of the biggest challenges is going to be the statistical work, how you set up the statistical concept behind the studies, and the fact that like in any computer programming, you need to enter proper data. The principal garbage in, garbage out is effective here as well. So we need to make sure that the machine is properly trained and the data entered is realistic and it makes sense. But to me, this was actually one of the things that I'm sure it's going to come more often in clinical trials. So I think it's important to be prepared and to understand how we can actually do clinical trials with synthetic cohorts, because it can actually have a big impact on the cost of doing clinical trials and also on the patient safety.